Hello, everyone, and welcome to the IHPC Interfaith Advocacy Network webinar to mark World Health Day 2026, which actually fell on Tuesday, April 7th. I'm Dr. Catherine Pettis, Senior Advocacy and Partnerships Director, and the theme of World Health Day today, well, not today, on the 7th, as I said, is Together for Health, Stand with Science. And this is created by the World Health Organization every year with a different theme. And IAHPC endeavors to do this through our research, education, and advocacy programs. And as you'll hear from our moderator, Richard Bauer, a bit later, through faith-based palliative care, which is aligned with science. I'm going to tell you briefly about the IHPC, the network, and the discussants. Very briefly, please put your questions in the Q&A so I can keep track of them, and we'll try to answer them. We'll send a short survey after the webinar, so please fill it out once we sign off. Your anonymous responses will help us improve our work and bring you more such events. And we'd also like you to introduce yourselves in the chat and tell us why you're particularly interested in this webinar. And if you're a spiritual care provider or a palliative care practitioner or both, we just want to know as much about you as you are willing to share. Next slide, please, Tanya. So the IHPC's vision is a world free from health-related suffering. And with more than 1,300 members in 135 countries, our mission is to serve as a global membership organization that empowers individuals, civil society organizations, and governments so that every person with palliative care needs has access to appropriate treatment and care. We're in official relations with the World Health Organization and in consultative status with the UN Economic and Social Council, where we advocate for global normative frameworks for palliative care. Next slide, please. The consensus-based definition of palliative care tells us, and you can find this on our website, that palliative care is the active, holistic care of individuals across all ages with serious health-related suffering due to severe illness, and especially of those near the end of life. It aims to improve the quality of life of patients, their families, and, very importantly, their caregivers. It includes prevention, early identification, comprehensive assessment, and management of physical issues, including pain and other distressing symptoms, psychological distress, spiritual distress, and social needs. And wherever possible, these interventions must be evidence-based. Next slide, please. Founded in 2025 at the World Health Assembly side event because the unmet need is so high, the Interfaith Advocacy Network we've identified that we have natural education and advocacy partners in the global faith community. Most of you already know the challenging statistics in the world, that only 14% of people who have palliative care needs globally can access those services, and that's a WHO statistic. Serious health-related suffering is rising with aging and NCDs, non-communicable diseases, including dementia. And this rise in serious health-related suffering has consequences that touch the faith-based communities, families, communities in general, and the household economies, because it's such a burden for some people to take care of someone who's seriously ill, as you know if you've done it. It also produces complicated grief if there's no good palliative care. So we also have identified that public and faith leader knowledge of palliative care is low, and clinician knowledge of spiritual care and religious principles tends to be low. So we're trying to fill that gap. Next slide, please. The Advocacy Network is developing educational tools to tackle the common misperceptions among all the faiths, such as the idea that palliative care means giving up and is only for patients at the end of life. That's just one of the misconceptions. Palliative care is only for cancer patients. Palliative care is the same as euthanasia or assisted suicide. And none of those things are correct. So the result of them is late referrals, avoidable suffering, and weak advocacy for access. The evidence, as you will hear from Chaplain Rick, supports spiritual care benefits for people of all faiths and people of no faith. Palliative care chaplaincy is growing and flourishing, but basic faith-based leader education on palliative care is rare or absent. Next slide, please. These are our esteemed discussants who you will hear from. Two of them are chaplains who are pastoral councils on interdisciplinary teams. Francine Hernandez, Bruce Feldstein, Abjit Dam, a palliative care physician, and Carlos Centeno, also a palliative care physician. I'm putting their short bios and impressive credentials in the chat for you to read. And I will now introduce our facilitator, Chaplain Richard Bauer, and then pass the floor to him so he can introduce your discussants and begin the question, answer, and conversation. And as I said, please introduce yourself in the chat, say where you're from, and what drew you to register for the webinar. Last slide, please, for me, Tanya. So Chaplain Richard Bauer, BCC, Board Certified Chaplain, Master of Divinity, and Master of Social Work, is on the staff at George Washington University for Spirituality and Health. An ISPEC, that stands for Interprofessional Spiritual Education faculty member, and a clinical assistant professor at the George Washington University School of Medicine and Health Sciences. He provides outpatient spiritual care at the GW Cancer Center and inpatient services on the GW Hospital Palliative Care Consult Team. Rick had previously served for 25 years in East and Southern Africa, coordinating support programs for people living with HIV and working to integrate spiritual care into healthcare. He has served on the board of directors for the African Palliative Care Association and is currently on the executive committee of PAL-CHASE, Palliative Care in Humanitarian Aid Situations and Emergencies. Rick is a global advocate for palliative care and the biopsychosocial spiritual model of palliative patient care and support. So Rick, you have the floor and I will turn it over to you.
Well, thank you so much, Catherine, and thank you so much for everyone, for our panelists, and for everyone that's joined today. Those of you that know me or have heard me know that for the last 44 years, this has been my passion. How do we integrate patient-centered spiritual care into our clinical care? And I began 44 years ago, and I'm still doing the same lecture, Spiritual Care, the Essential and Neglected Component of Palliative Care. And so I'm so excited to introduce, our panelists and to get this conversation going, especially when we're talking about now Together for Health and Together for Science, because the field of integrating spirituality into clinical practice and the research and the evidence has skyrocketed in the last 5 years. And I point you all to this incredible article in JAMA, the Journal of the American Medical Association, that said, hey, if we're not integrating spiritual care into our clinical practice, we are really failing our patients. And that's whether or not somebody has religious beliefs. What we mean by spirituality is that which brings meaning, purpose, and connectedness to people. So I am excited for this webinar. And as Catherine said, please put your questions in. We're going to be a little short and focus our presenters on just 5 or 6 minutes so that we have some good discussion going on. I was going to introduce Dr. Hernandez, and she's off my screen.
Oh, Dr. Hernandez, are you there? I hope she didn't disappear.
Well, I'll wait for her to come back. How about Dr. Dam is the founder and medical director of Kosish, the Hospice Jaharland, the author of several books, Wading Through Quicksands, Palliative Care, Spirituality, Santan Dharma, and a commentator on palliative care in India and traditional foods of India. So I'm hoping every one of our presenters can speak a little bit about palliative care from their own personal religious background, but then how do we advocate to integrate spiritual care into clinical practice? Dr. Dam, I'll turn this over to you.
Okay, so let me share my presentation. There we go. So, discussing about faith and its role in palliative care. Sustaining hope. When I started off my practice in palliative care in a rural setting in India, almost 25 years back, sustaining hope in the face of hopelessness was one of the greatest challenges that I actually had to endure. And added to that was answering questions on existential dilemmas and issues related to spiritual and religious issues, where I was absolutely floundering. And then I got thinking, and I started asking myself a few questions like, what was the difference between treating and healing, pain versus suffering, faith versus trust? And at that point of time, I was a very strong atheist. And I went to such centers. I prefer to call these buildings research centers, because you go to a research center with a particular research question. And once you come back, once you leave that center, you come back with some answers. And these buildings could be temples or mosques or churches. It could be any religious place. So faith was at the center of all these so-called research centers. And of course, then I think almost all of us are aware of the famous quote that Albert Einstein had quoted while at Princeton. He had quoted that, does the moon really cease to exist if we do not look at it? And quantum physics had actually come and answered in the form of the observer effect by the Copenhagen interpretation of quantum mechanics, that actually particles do not have defined properties until they are observed. Faith was something like that. Unless you really started experiencing faith firsthand, you would not know what beautiful and miraculous properties it could afford in the face of hopelessness. And so my own journey began, my own evolution began, and I evoluted from a well-read physician to a person who was gradually grounded in the local culture, in the religious practices, and who began to respect other branches of medicine as well. And gradually, I found myself being able to answer questions, provide hope in the face of hopelessness, And most importantly, I began to understand myself in the whole process. And as William Thomas Cummings had quoted that there are no atheists in foxholes, this was a statement which I found to be so very true, especially when you're dealing with suffering. Coming to the Hindu perspectives, there is nothing called a theist or atheist or agnostic. In Hinduism, we just have two categories. One is the astic and the second is nastic. An astic is a person who believes in the scriptures, who believes in the teachings of the scriptures. Scriptures out here means the Vedas, the Upanishads, the Bhagavad Gita, and the Brahma Purans. So a believer in the teachings is called an astic. And very close to the faith systems is ritualism. And I couldn't but quote this beautiful definition of a ritual as quoted by Thomas More, that any action that speaks to the soul and to the deep imagination. Such a beautiful definition of a ritual. And faith definitely has a great role in promoting resilience. Like this lady who traveled almost 1,000 kilometers in spite of a terminal illness so that she could hold her grandchild for the first time in her lap before she finally passed away. And my own evolution in this journey began. I found that faith could provide connection. It could help to restore a sense of meaning. For suffering often seeks validation to blossom, and faith provided that validation. To provide a companionship in the process of dying. And then I found that a large number of my patients were having end-of-life dreams and visions which really couldn't be explained by scientific norms, by the classic scientific norms. And faith and belief could help out these patients, could help them come to terms with this end-of-life dreams and visions. Faith could help in transforming suffering. Ritualisms, again, which are very well linked with faith, with the faith systems, they actually could provide a sense of healing. So when we talk of healing in Hinduism, we have four major systems. One is Ayurveda, second is yoga, third is astrology, and fourth is music. Music therapy, as you're very well aware, we use it extensively in palliative care in various forms, which would be, again, culturally appropriate. Here you can see is the Siddha system of massage, which is being given to a terminally ill patient, which helps in promoting relaxation, promoting sleep. These are non-pharmacological modalities of therapy, again based on various faith systems. And in Hinduism, we have the 16 samskaras, which are sacred rites of passage, which helps in character building and maintain social order and support. These 16 samskaras start right before birth. Starts with Garbhadharanam, Pumsavam, so on and so forth. And then at the end, we have the last rites, which is called the Antyeshti also. So all these samskaras helps in reinforcing the faith system, and it helps to transcend suffering in some way or the other. There are four stages of life in Hinduism, beginning with the brahmacharya through to the grihastha ashram, that is the householder, and the vanprastha ashram, which is basically the retirement phase, and then the sannyas ashram. These are very well described, and they provide a sort of guideline as to what path a person should be taking in which phase of life. Having children. Now, children, as described in our scriptures, children are people who free the parents from the clutches of a realm of suffering called the put. So children out here are seen as persons who would help the parents transcend suffering. And no wonder in the Brihad Aranyak Upanishad, there is this dialogue which says that Tvam Brahma, Tvam Yagna, Tvam Loka iti, and the son says to the dying father that Aham Brahma, Aham Yagna, Aham Loka iti, and so on and so forth. And in this picture, you can see this dying lady who is lying on this cot. And she derives a sense of meaning and purpose by her grandson, that little child who's sitting on the mud. So the presence of that grandson gives her a sense of meaning, purpose, and connectivity. So that
Dr.
would be so.
Dam, I would love for you to go on, but if you can begin to wrap up, that would be great.
Yeah.
I'm
I'll
fascinated.
do so. I'll do so. I understand. So there are various types of ritualism, and so on and so forth. Uh,
Mm.
well, I'll end here. This is the final rites, or the rites of passage. Well, that's about it. Thank you for your time.
Thank you. Thank you so much. I've got a lot of questions. I hope our audience does too. But right now, thank you, Dr. Hernandez, for showing back up on my screen. You panicked me. Dr. Francine Hernandez is an ordained Baptist minister, distinguished leader in pastoral care and education, and she's the director of pastoral care at New York Presbyterian Hospital and the president of the College of Pastoral Supervision and Psychotherapy. Welcome, Dr. Hernandez.
Thank you so much. And that was former director at New York
Oh,
Presbyterian. I'm at St. John's Hospital. That's okay. But I do apologize for being disconnected. It's raining in Florida. What I wanted to, my part, I really want to issue a challenge to those who might be in the clergy world or those who are connected to other churches, synagogues, mosques, or whatever. How do we bring together? I wrote a book in reference to stay in your lane. Clergy need clinicians. Churches need clinicians. So it's a challenge to you all who are listening, a part of this webinar. Begin to find ways to connect with clinicians so that we can address the fact of people who are suffering. I served as a counselor of HIV/AIDS in Miami, Florida for years. And the stories that I heard of people, they are longing for spirituality. So we got to find a way to connect those two. I learned that faith is not about having answers. None of us have the answers. So it's not about having answers. It's about being present. You may not know what to say or how to say it, but how can you be present? It's about having the courage to sit. I wrote a book in reference to about a cave walker. As clinicians, we are cave walkers. We know the value of walking into that dark place with those who are suffering from HIV/AIDS. And sometimes it has become a stigma and they feel it. But how can we create that space where empathy is being shown? So I am really challenging those who are listening, find a way to connect with clinicians and clergy together. Find a way to bridge the two. I love this title, Bridging the Two Together, because we're looking at the holistic approach of working and being with those who are dealing with the illness of HIV/AIDS. We need partnership that welcome them as collaborators. And we need to find a way to come together. I'm hoping that those who are listening will find a way to partner with clinicians, partner with those who are working with HIV/AIDS. I was watching the slide of the previous presenter. It is a dreadful disease, and the disease has affected the body, but the mind is still searching and hoping for someone to come to the cave, to come to those dark places and begin to listen on a different level. And Rick, I applaud you for the work that you've done down through the years. And we are hoping that other partners would join you and be more concerned about what's happening in the world, because it's a serious illness that is not just physical, it is emotional and relational and deeply spiritual. People who are struggling. I had a brother who died from HIV/AIDS. And as a family, we had to walk the journey with him so that he felt cared for, knowing that someone was concerned about him as a person, because the disease was not him. He is still a person. So how do we come together and see people who are suffering as people with dignity? And they are deserving of our bringing a chair. I wrote another book, Rick, called Bring a Chair and Not a Needle. They are not looking for us to fix them. They're looking for us to bring a chair and to sit with them and to hear their stories. So I want to applaud this panel who discussing how do we bridge together clergy, clinicians, and community to come together and address HIV/AIDS. Hallelujah.
Beautiful, beautiful. Thank you, thank you. And again, a passion after my own heart. And I would say
Yes.
not only HIV infection and AIDS, but cancer and all of these life-threatening illnesses, Alzheimer's
Any
diseases,
disease.
major kidney disease,
Yes.
chronic heart
Yes.
failure, all bring up these
Yes.
questions, not that
Yes.
only that need, thank you, we need our physicians, but also bring up, why is this happening? Who am I?
Yes.
You know, that young
Yes,
mother
yes.
that now has terminal breast cancer. Who am I?
Yes. Yes.
And answering those questions, those deeply spiritual and existential questions. So I just love it. It is my delight
Yes.
to introduce my friend and buddy, Dr. Bruce Feldstein. It is great. He's a board certified chaplain and a physician and the adjunct clinical professor of primary care and population health at Stanford Medicine. And he was the founder of the Jewish chaplaincy services at Stanford Medical Center. So welcome, Bruce. The floor is yours.
Thank you, Rick. Thank you, Rick, and Dr. Dam and Dr. Hernandez. I am inspired by you, and I think I'm going to throw away my whole talk and just start speaking from the heart. But I do have a couple of slides here. So, Tanya, if you could show those for everyone. I'm going to focus on Judaism and palliative care. I bring a background, as Rick mentioned, as a physician who's a chaplain and also an educator. And I want to include my part of what ignited my heart in this work was going to Thailand to work in a Cambodian refugee camp in the winter of 79-80. And it was there where I witnessed. And witnessed is something that you just don't see, but I felt it, you experience it. It's that inescapable joining with the compassion of not only the individual children, but also the people as a whole who are suffering in the effect of that genocide. And that kind of opened my heart and led me into emergency medicine for 19 years. And then for the last 26 years as a chaplain at the bedside with really, just uncounted thousands of patients. Next slide, please. And my work has been at Stanford School of Medicine and also out in the community and around the world. And that's where I had a chance to meet my friend Rick. Next slide. So just a comment about Judaism. We're a small people. I think we make up 0.2% of the world population. And in America, it's about 2%. But we're people with a voice. And we speak and we share what we do on behalf of others, of all people. Judaism is a faith. Judaism, as I've come to immerse and discover for myself in my work, it's a worldview, a way of living, a way of being in the world. And it's got a history, and it's got a long history. And it's a history of people in the world with other people. There's a whole range of different religious, ethnic, cultural backgrounds. The first language of some of the people I've been with includes not only English, but Spanish, Hebrew, Yiddish, Italian, German, Arabic, languages from India as first language, and many others. And as we go in to visit patients, as I go in, I recognize that each human being is made in the image of God. As we say, B'Tselem Elohim. So that's across the range of backgrounds. This is something that is true for Jewish people in general. And we recognize the human being as a body and a soul. This is an idea that's really thousands of years old. And this body, our life, is not our own. I said, what? Not my own? Yeah, that's right, they said. It's a gift. It's a gift from God, or it's a gift from the source, or it's a gift from whatever language, from Atman, from Allah, from whatever language we use for that mystery to which we all belong. We belong. Our belonging is already here first. Our belonging, the happening of life, which gives rise to this human being. That's here first, and then who I am, and recognize myself as a unique individual, that arrives later. Next slide, please. I mentioned some of the different cultural groups as reflected in language, and I hope when I speak here, because I just have a few minutes, there's so much I would love to convey, but if I can convey just some of the spirit of being Jewish in the world, which is really another way of being human. We're born not only of stem cells, but as I've come to believe or recognize, not just believe, but know, we're born of stem souls. There's something in our humanity itself that has a stem quality that later unfolds into and differentiates into the beautiful flowering and tree of life, which is our broad humanity. Judaism, curiously, is not about a belief system, although we have beliefs, but it's at its core about actions of living, actions of caring, actions of compassion. The word that we like to use for that is mitzvot. Next slide, please. And there's some guiding principles for palliative care. Let me just go over a few of these. First of all, life is sacred. It's a gift. Life is sacred. And in palliative care and in Judaism, we do focus on the quality of life. A lot of people think, oh, life is so precious. What's most important is the extension of life and how long it is and at all costs. But no, we do focus on the quality of life, and we recognize that life is precious. Indeed, down to the very last breath. Whenever that last breath comes, whether it's after 5 minutes of life or 108 years of life. And we also recognize that we belong to life, and there's a lot of uncertainty and a lot of mystery, and this includes in medicine. And so we recognize the reality of medical uncertainty and the facticity. I like that word because sometimes it kind of gives a punch. You know, we are mortal beings, but we can forget that. So we recognize that. And we also acknowledge our patients have a choice. And decision-making, next slide, please. Decision-making is a joint process. It's not just one-on-one, but I think of our medicine and our care of patients is one on one on one on one on one, depending and looking at all the people in the networks of relationships. So that includes the faith leaders. That includes the rabbis, the chaplains, the people who speak on behalf of the faith of the individual. And so that's part of my job as a practitioner, as I ask, do you have any spiritual or religious practices or customs that are important for you? And then I listen for who that is for that unique person. It may be someone who's particularly religious. I want to go with that. We also have Jews who I say, one Jew asked me or wanted to let me know, he says, you know, I'm not religious. I'm a Jew by appetite. I'm a Jew by appetite. And he sure was. And, you know, I respected that. And we joined in that. So I think these are just a few of the things that I have to say. I hope, you know, I wish like Dr. Dam I had slides of all the people and places that I've been. And I love the idea of the place of worship as a place of research. And Here's the thing about science, and I have one foot in science. Science is so much about the evidence and the statistics, and this truly is important. And yet, the individual person is an N, as they say in statistics, an N of one, an unique individual. And so, my aim is to join with them in their world as it is for them and accompany them. That's my core verb, accompany them from there. I'm not hearing you, Rick. You want to unmute?
Thank you. They muted me. So thank you, Bruce. And I often struggle with this myself of, and in one hand, that evidence-based, what is good spiritual care to do assessment and spiritual diagnosis and good interventions to treat spiritual distress, but never, ever losing, on the other hand, the mystery, the awe of being in the presence of this other human being. And and never losing the mystical and the miracle that comes from the work that we do.
That's why we have two sides of our brain, Rick. We have our analytical side and we have our holistic side. It's both and. We live in a both and world. And that's why God gave us the corpus callosum, for those who know. Those are the connecting fibers of the brain, and they go down to the heart and out into the mystery of all.
Amen. Thank you. Thank you. And our final presenter is Dr. Carlos Centano. Bienvenido. It's been muchos años. A palliative care physician in Pamplona, Spain, is an active member of the Pontifical Academy for Life, a full professor at the Faculty of Medicine at the University of Navarra, and the director of the Department of Palliative Medicine at the Clínica Universidad de Navarra. Bienvenido, welcome. It's great to see you. And unmute.
Thank you, Richard. Thank you very much. I'm very happy to be here today with you and with all of you, so people of all around the world, talking about the spiritual issues and religious care of the patient at the serious moment of the life. My perspective today will be the perspective of a person that is a Catholic doctor that is working in a Catholic institution. So this is my perspective. It's not the perspective of a professor, but the perspective of a simple doctor that is at the side of the patient. First, I will talk a little bit about how a Catholic institution makes room for faith. And after that, I will say briefly about my own personal perspective, how I try to do this spiritual care from my own religious perspective, that is the Catholic one. First, my institution. So I work in a Catholic institution. This means that religion and spirituality are not excluded, but naturally presented and respected. The institution fosters a climate where spiritual care is considered part of the whole person care. In my hospital, spiritual care becomes visible because in many ways, or in different ways. First of all, because we have a chapel. We have a beautiful chapel in the basement of the building, but also we have a small chapel, a small oratory for silence, for recollection, for meditation, for patients and also professionals and caregivers. Every day, a chaplain visits patients regularly, especially those that are more seriously ill, as the oncological patients, intensive care patients, and other patients in situation of gravity. So every day, the chaplain say hello and visit that rooms. In this way, the institution makes the presence of God available of the daily care. Also, we have in the rooms spiritual things, religious things. We have in every room usually an image of the Virgin Mary and a crucifix. They are not decorative objects. They are things of company, of hope and meanings. Also, we have the sacraments because the chaplains, but not only the chaplains, but the priests offer the sacraments to those that wants to receive it. But not only the chaplains, because the professionals are used to offer also this sacrament to the people that wants to receive it. And this is something that is promoted in the institution. So people from faith or people without faith offer the sacraments in our institutions. But all this visibility of the presence of God in the daily care is also and probably mainly present in the respect, in the dignity, and the ethical care that we are promoting in the hospital. The atmosphere of the hospital is the respect of everyone, the respect of every faith, of every belief. The care is centered in the person really, and we recognize the dignity of each human being. It's very well known that in our hospital, the euthanasia is not practiced. So the ethical dimension is not marginal, it's present in the daily work. Patients usually know this and perceive it, and in general is practiced without any problem. Some share it, others simply respect it. So the key idea is that in our institution, spiritual care is not an extra, it's part of an environment where the person is cared for as body, mind, relationship, and spirit. What about my own professional perspective, or my own personal, I will say, personal perspective? As a Catholic, the lesson that I learned is coming from Jesus Christ. Jesus is our model. Jesus is the way, the truth, and the life. Therefore, in our professional practice, we try to follow his example, his teaching. And the teaching of Jesus about how to care the more ill patient is coming from the gospel, and in a beautiful and very short parable that is the parable of the Good Samaritan. For those that are not familiar with this small history, a man was attacked in the way and was robbed and left half dead on the road. Then two religious persons pass by, they see him, but they don't stop and don't help him. Later on, a Samaritan, a person from other people, from other race, arrives, and he moved with compassion and approaches the man, treats his wound, and takes him to a safe place. He pays for the care of that person and promises to return. It's very clear from this teaching something that is essential in palliative care. This is the model. In this parabola, we find many central elements of palliative care. He allows himself to be moved by compassion. He approaches the person that is ill. He cares for him concretely. He uses the means that he has. He seeks additional help. He builds a team around the person, and he commits himself personally and promises to restore. This is palliative care. Palliative care is compassion that becomes action. Palliative care is personal involvement. Palliative care is practical intelligence. Palliative care is continuity and responsibility. This is not only feeling sorry. That we learn from Jesus is to care everyone with ourselves. But in addition of that teaching, we know from the gospel that we can see Jesus also in the patient that is very ill. Krishna is only in the way that we are imitating him. He's also in the one that we recognize as sick person. What you did for one of these little ones, you did for me. I was sick and you visited me. And the Catholics knows this. And we try to practice when we are going to the side of the patient. We are not seeing only a person, we are seeing also Jesus Christ in that suffering body. Palliative care for a Catholic doctor cannot be done without a reflective practice and an interior life. The professional needs to reflections, and if he is connected with God, many times can perceive, can feel that something different, something spiritual is happening in the room. But he has to be connected with God and feel that something big, something great is happening in the room. And sometimes are moments of forgiveness, other times moments of reconciliation, other times moments of love, of peace, of return to God. And these are often intangible moments that we not produce. We don't feel this of something that we are doing. It's something that is happening through ourselves. And this is the way that we perceive spiritual care and the way that the Catholic practice palliative care in the daily way.
Thank you so much. Thank you so much, Dr. Centeno. And you brought up something, and Liliana, this is another webinar that I know Dr. Feldstein and I are both interested in, is that spiritual care for staff and medical students and residents that are new to palliative care, and how do we respond to their spiritual needs? I'm glad you brought that up. But another webinar that we can have, spiritual care for staff. But I want to throw out my first question, and it's come up, and I know there's a lot, and I'm so excited. But for many of us, one of the first signs of spiritual distress, especially in our hospice patients, is that death anxiety, that patients that are just terrified of dying. I know, Dr. Dom, you spoke of this in the beginning about hope, but my question for all of you, any of you, is how can rituals and spiritual care respond and comfort people that are facing that death anxiety?
I have not an answer to that, but that I have not an explanation to that. The explanation could be different in different faiths. Perhaps it's the action of the divinity in the person. But without to have an explanation, that I have is my own experience. This is that I'm seeing when one patient, through one ritual, through one sacrament in my hospital, are receiving that sacrament, becomes peacefully, becomes this is my experience. So I cannot say in any other word. I'm seeing that. You are muted.
Unmute, Rick.
Bruce, go ahead.
Okay. I'm inspired by you, Carlos, and I want to talk about an important ritual, which is the ritual of preparing oneself in going to see an individual patient, recognizing that recognizing the visit as a sacred architecture and time. And it's one that I create with my attention and intention prior to going into the room. As I enter into the room, I first stop to let go of my preoccupations, to ground myself right here and now. And then as I go into the room, I remind myself, as I enter the room, may I meet you, my patient, in your world as it is for you, and accompany you from there. And I recognize in this world that this world includes the body of the person, the soul, all of their connections, including with mystery itself. And so I can open to that a clearing, we might say. And as I come in, may I join with you and accompany you, and to listen for what and be with you in wherever you are. What matters for you is what matters for me. And in that quality of presence, I ground myself, no matter whether it's in a place of suffering, of fear, of the distress of death, or a celebration of life. It's all always already present. And so I can join in that way. And to use a medical analogy, it becomes a little bit like when somebody goes into the MRI machine, there's a magnetic field that starts to whirl. And then what happens because of the physics of that, and that's the same with the physics, I believe, of our attention and intention, that magnetic field causes the magnetic forces or the electronic forces in each cell of the body to now align and attune with the field. Well, when I can bring a field of calm presence in the wholeness of this all, it allows the person in distress to know, first of all, I am not alone. Someone is here with you and unafraid. And then if I do have to give some language to it, I could tell the person, our body, when we came into the world with our first breath, it came with instructions on how to take our last and how to move on. And the body already knows exactly how to let go. And in the same way that we labored coming into the world, and then here we are, we're going through a labor, but there's somewhere after that's a relief of the suffering and the pain to which we're going. And the quality of presence and sometimes a helpful thought can be comforting. So that's this idea of ritual and architecture as our presence is what I want to offer as a response to your beautiful question of ritual. Unmute, Rick.
Dr. Dom, can you add anything from your experience about ritual and it's maybe even ritual? My other question is how we as palliative care professionals can also provide spiritual care and that comfort to people that may have a different belief system than myself.
So if we come to Hinduism basically tells you that you are not exactly your physical body. You are different from your physical body. There is a concept of Sharira Traya, that is the physical body, the Sthul Sharir, the Sukshma Sharir, that is the subtle body, and the Karana Sharir, that is the causal body. So in Hinduism, we do believe that it's only our physical body which falls apart at the point of death, and something that lives on beyond our physical body, which leaves the physical body at the point of dying. So most of the rituals in Hinduism are designed to help the subtle body exit the physical body during the process of death and dying. And faith out here, faith has an important role to play because it is the belief system. It is the absolute. It is like, like that little child you hold who clutches on to the helm of the dress of the mother and follows the mother blindly and confidently. So it is something like that. And religion out here is something like the mother, guiding the child onward. And then again, what Hinduism teaches is learning to let go, teaching to open your fist, the sooner you learn to open your fist. And that is why there are the four ashramas of life. That is the Grihastha ashram and the Sannyas ashram and the Vanprastha ashram, where the teachings teach you to gradually let go of your attachments and then gradually embrace, the inevitable. So there are so many rituals surrounding all these teachings, basically. So I hope that answers your question.
Thank you so much. I'm going to, if it's okay, Catherine and Lilian, there's a few questions in the chat. I may try to answer a little bit. Providing support through if the patient is agnostic or atheist or different beliefs than my own. Again, another webinar is how do we screen for spiritual distress? How do we put spirituality for you physicians in your history and physical? And then how do we do a spiritual assessment? And that basically gets at what is important to the patient. You see, this isn't about my spiritual beliefs. This is about what the patient believes and what brings meaning, purpose, and a sense of connectedness in that patient's life. I would say about a third of my patients now, both outpatient and inpatient, are non-believers or just unsure. And so what's meaning and purpose may be their role as a parent, may be leaving a legacy. It may be we just had the cherry blossoms here bloom in DC. It may be nature and seeing the presence of God or the presence of a higher power in nature, in water, the beautiful Potomac River. So it's whatever is important to that patient that we kind of go there. So many of because people, and especially at my hospital, know that about me, that I just jump in with those, that are questioning beliefs. There was another question, and this is so important, and I kind of answered that. What happens when the religious or spiritual beliefs of the patient are very different from my own? And we're struggling globally with this. In the US, in Europe, and Australia, we have the board certified chaplains, and we are all trained to do those spiritual assessments regardless of what my own beliefs are, and to either ourselves or we connect with community clergy to make sure rituals that are appropriate for that patient are present. I love what several of you said. This isn't about answering the unanswerable questions. The unanswerable question is, why is God doing this to me? And if you try to answer that question, I believe you're going to do more damage than help to that patient. We are not there to fix patients. We are there to be present in the face of spiritual suffering and questions, and creating that space. As Dr. Feldstein says, the body knows. I think the soul knows too. The soul knows how to heal and do this journey. Our role as spiritual care providers is creating that space. And I'm looking at our time, Catherine.
Rick, there was one question also, maybe we've got time to go through it if people can sit for a minute, about how, and each of the panelists maybe could do this, is how do you, I haven't got the literal question, but how do you use spiritual care to reduce death anxiety in patients, which I thought was very helpful because so many patients as well as caregivers have death anxiety.
If can answer, I will say that many times the spiritual care happen wordless, without words. And the summary of the spiritual care of one professional can provide is the presence of that professional. A person that is there, that is present. And this is the reduction of anxiety. If you are there, if the patient is with someone that brings safety, security to them, the anxiety decrease. So it's the authentic presence of a person that wants to help, that wants to care, that reduce the anxiety, in my experience.
Thank you. Thank you. Dr. Feldstein.
I echo again with my colleagues, Dr. Carlos, and about entering with presence, wordless, being unafraid. I mentioned that, joining you. But then also asking the patient, so tell me, what is it you're afraid of? And because I have no idea, it's clear they're in distress. And some people will say, I'm going to suffocate. And I'm so worried about that and the pain. Well, then a response can be, then we can attend to that. Or, I'm leaving my husband behind and he doesn't know where the checkbook is and I'm the one who keeps the checks. Oh, then we talk about that. Or, I don't know what happens next. And then we talk about living in mystery. So it's just helpful for people to ask, well, what is it you're afraid of? And that often will untangle a lot.
Yeah. I go back to, I had the absolute incredible mentor my very first year in Africa. We had a huge clinic, over 10,000 people with HIV, and this was before the availability of antiretroviral medication. And one day, I'm the spiritual caregiver. I was frustrated. It was hot, it was humid, there was no drugs, people were dying. And I said to Dr. Corrigan, why are we even here? And she looked at me and in her very British accent and stoicism said, our role is to stand in the face of horror and not run. And I echo what Dr. Centeno said. This is often, words are important. I love words, but often that, if the person is, what is next? Am I going to be saved? Am I going, what happens at the moment of death? To be present to mystery and to be present to that suffering, not with the answers, but with the connection of another human being. My own religious tradition talks about sacrament of presence. That when we are truly, and I go to Dr. Feldstein every time I go into a patient room, attention, intention, it's my mantra now. What's my intention of being present to this patient who may be dying?
Rick, I want to jump in with a question for maybe it's another webinar. Because what you said reminds me when I was in the refugee camp and I encountered the horror of seeing a little one who I had carried who had died. And we put in the place that was the morgue, and I came back later and I saw the ants crawling in and out of the face. And I literally ran away and vomited outside that little tent. At other times, I literally ran out of the room after giving a family news when I was an emergency doctor, and the wailing of this Middle Eastern family was so piercing, it shook my innards, and I ran out of the room. And yet, what did I end up going into when I tore 2 discs and I could no longer practice emergency medicine? I am now the guy called into those kind of horror moments of horror and stuff. So the question I have for all of us is, how do we build or train to have an emotional fortitude? The emotional fortitude that allows us to stand and be present and unafraid. It's learnable and it's not automatic. although it may be by the grace of something for some of us. So, how do we build or that kind of emotional fortitude as a practice? It allows us to be present in the face of the suffering, the horror, the injustice, the ugliness, but also the exquisitely anguishing gratitude and joy and suffering that also can be shaking. How do we learn to stand in the face of that?
And I see the last, from Pranab Basu, when a cancer patient asks, why me? Why God has given this to me? Okay, first of all, each one of you is going to have to figure out for you how to answer that. I can just share my experience. I'm the board certified chaplain. I'm supposed to have all the answers. And when a patient says to me, why me? I just immediately respond, I don't know. But I promise, to the best of my ability, I'm going to stay with you. And I discovered in my own life, the why questions drive me crazy. I go to the what questions. What is God asking me to do now? And sometimes I use humor, and you got to read the room with that. But I try to move people away from the why questions, because I find, and again, this is my personal experience, those pat answer questions, especially with pediatric palliative care, are never helpful. God never gives you more than you can handle. God needed another little angel in heaven. They're never helpful for parents that are losing a child or for an adult. But if we can move to the what questions and maybe even some of the how questions, then I see healing happening.
Mm.
Catherine, I'm looking at you because you know me. I'll go on for the rest of the afternoon with this discussion, but I want to be aware of our time.
How about we just do a last round of 1 minute final reflections, starting with Dr. Dam. And I want to remind everyone, as I've been doing in the chat, please stay on for the survey. And if you don't stay on, you will get an email asking you, so we will be chasing you. So the final round, and thank you everybody so much for attending and for presenting. It's been such an honor.
And just to clarify or add to what Catherine just said, survey is anonymous, so please, be as honest and brutal as possible. We want to know what you think about the survey and how you rate us and all the panelists, because we use these to prepare future webinars as well. So thanks again, and thanks to all the panelists. Yeah.
So last thoughts, Dr. Dam?
Unmute.
Oh, unmute.
So dying, as I see it, is not a one-time event, just like a switch. You don't flip a switch and say that you die. Dying is a process. So that process could extend over weeks, days, months, or even years. So the process of dying requires preparation. And that preparation can be in the form of ritualisms. Religion could have a role to play. Spirituality definitely has a role to play in that. And every religion has their own ritualistic practices, which definitely help in this preparation for this final great event of our life. And especially, say, in Hinduism, in Tibetan Buddhism, we have certain practices like the Pova or the Tonglen practices, which definitely go a long way in helping to transcend this transition. So that is how I see it. And faith is so very important. Faith is that cornerstone which which is literally non-negotiable at that point of time. That's how I see it.
Bruce?
Thank you, Catherine. I'm leaving today with just immense gratitude, appreciation for the commonality that I cannot help but hear among all of us, including all the listeners when I look at where they come from and in their questions. And I just stopped to say, well, what guides me personally is through my life is asking some questions, and I don't know the answer, so it's about living the question, knowing gradually, as the poet says, I'll live along someday into the answer. And so, two of those questions that always guide me: where is my heart? And not just like cardiac muscle, but an organ of vision, an organ of caring. Where is my heart? And what is this alivening, continuous aliveness, continuing aliveness? What is this alivening in me that is me? And also that is in you, my patient, that is yearning to be revealed and lived. What is this alivening in me that is yearning to be revealed and lived, including into and through the last breath and beyond?
Carlos?
So finally, I will say that when we are talking about the spiritual care, religious care, spirituality, it's normal to be worried about how to do it, how we can provide better spiritual care. But we never forget that in spiritual care, there are two streams, and we are not the principal. So it's something that happened between the person and the divinity, the person and God. So we are not important. The important is that it's happening between these two, in the patient, between the patient and between God. We have to make room to God to act on the patient.
Rick, do you want to close? That was beautiful. No, you're muted.
Just thank you. Thank you all. I just, and Liliana and Catherine, IAHPC, you can see the hunger for this topic. So I know our next webinar we're looking at indigenous spiritualities, again, throughout the world, and how we in palliative care can be aware of that and those patients that embrace an indigenous spirituality. We have lots of topics. I saw a lot on pediatric palliative care and spiritual care for pediatrics, both the child, the siblings, and the family. That's another webinar. And spiritual care for staff, would love to do that because I know in the United States, Europe, I always say I went before COVID. I was doing 10-90, 90% patient, 10% staff. It is now 50-50. And especially with the huge burnout rate of physicians and nurses and social workers and other clinicians in healthcare. So much of our work now is with staff, many of whom have vague or no religious traditions, but are interested in that meaning and purpose in life. So thank you for hosting. Thank you all of our presenters. Thank you too for we had, I think it was about 130 or 140 people at one point. So we had great participation. And thank you for all your questions.
And thank you for great moderation, Rick. That really was super. So we'll see you all soon, and have a blessed rest of the day wherever you are. And thank you for your work.
Thank you.
Bye.